Hi all, it's Jess, and I am recording today some different notes that Cindy Jones and I had put together for preoperative and postoperative patient preparation and patient care. So I'm going to share my screen so you can see what I'm talking about. And there we go. So for preoperative and postoperative patient preparation, there is a lot of going on in a very short amount of time. Let me advance here. So first of all, why do we do surgery? In terms of what's going on and why is this important? Why is this important? We do surgery for a few different reasons. We can use it as a diagnostic. Think of people who are getting like a colonoscopy. That's technically a surgery, involves pre-op and post-op and some anesthesia properties in between. But the reason why that procedure is happening is for diagnosis of and looking for polyps, cancerous problems in the bowel, other problems with the bowel as well. So we can really figure out what the heck's going on in that bowel. There's several different types of diagnostic procedures that people can go and be a part of. There's diagnostics that happen in the cath lab for hearts and for brains. There are diagnostics that happen in general procedural areas, colonoscopies, like I said. Perhaps somebody needs to have a tumor removed to be able to do biopsy and lab studies on that to see what the heck's going on with that particular tumor. And then there's other diagnostics as well. Excuse me. So in addition to diagnosis, we can cure things. So like, let's say for whatever reason, we do have a tumor and it just gets removed. But it's not necessarily cancerous and it's not really doing anything, that's a cure. Maybe we had somebody who has chronic arthritis in a knee and they don't have any cartilage anymore in that knee. It causes them a great amount of pain. So we'll do a surgery to be able to remove the bone-on-bone situation and replace it with a steel ball joint sort of situation. And that's a cure. We can use palation. Palation is removal of pain. So let's say somebody's got a tumor on their spine. We can actually, or a tumor pressing on something else that's causing a great deal of pain, by removing that tumor or by removing that mass or by removing that whatever, that is a relief of pain. We can do it for prevention. There are many people who elect to have preventative surgery. One that definitely comes to mind is there are people in the world who have what's called the BRCA gene. It's a genetic thing, and it puts them at incredibly high risk for breast cancer. So what people with the BRCA gene can sometimes do, they can elect to do this, is they can do a preventative surgery by having elective mastectomy and having those breasts removed, therefore preventing their ability to have breast cancer. There's exploratory surgery. We don't know 100% what's going on, but we've got a very sick person here. So sometimes exploratory surgery will be done. And then there are cosmetic improvements as well. I know that people sometimes think of cosmetic improvements as like boob jobs and nose jobs. But let's say for whatever reason you have one of the cases that really comes to mind when it comes to cosmetic improvements is I had several different clients that I cared for in the hospital, and they were there because they had some sort of cellulitis or some pressure ulcers and pressure injuries, whether they were healthcare acquired or not, pressure wounds. There's a few different ways that people refer to that. So regardless, they were in there and they were having skin flaps removed from one area, usually their upper thigh, and that skin flap was therefore being transposed to a different area of the body to where the tissue wasn't just unable to regenerate itself. So one gentleman I know had a pressure injury on his sacrum. It was really big. Once we figured out and got all of the infection out of that area, because it got infected. Once we got all the infection out of that area, he actually came back to the hospital, had cosmetic improvement surgery, so he had a skin flap from his upper thigh. And then that was grafted to his sacral area, right at his tailbone. And then I actually had a chance to have him 2 years later as a client as well. He was in there for something else. And this is probably the only time that it was socially acceptable as a nurse to be able to say this, but I got so his butt looked really good because I had him for his wound care problems. And then after this cosmetic surgery and everything was healed really well, his butt looked really good. All right, so let's move on to the next here. So there are some different vocabulary words that are associated with pre-op and post-op. So something ectomy, something lysis. So what happens with the language for pre-op, post-op is whatever it is, and then what we're doing to it. So like if we have an ectomy, that means a removal. So a colectomy means we're removing part of the colon. Lysis means we're taking something out. What I encourage you to do to be familiar with all sorts of different sorts of suffixes, meanings, vocabulary, because sometimes that's where people get tripped up in nursing school, is on your own outside of this video lecture, take this slide and fill it in. Get together with a group of people, get together with your buddy. Maybe you have a study buddy, maybe you have a study group. I don't know how your study skills work. Divide and conquer this, and then come up with not only the meanings, but the examples as well. Moving on. Okay, so there are several different nursing diagnoses, otherwise known as problem statements. So you'll hear me refer to them as problem statements or nursing diagnoses, nursing problems. I kind of have a few different vocabulary words about that, and I apologize for that. Diagnoses was the old school way of referring to it, but sometimes I like to just refer to it as a nursing problem because diagnostics get really confusing. The word diagnosis can get really confusing with like medical diagnosis, and nursing diagnoses and medical diagnoses are two different things. So you'll often hear me talk about problems as well as diagnoses, just to let you know. Welcome to Jocelyn. So some common ones: knowledge deficit. Knowledge deficit, usually our primary intervention for knowledge deficit, so we're going to be doing patient education. Fear. This is a huge one. Imagine that, because whenever anybody's in pre-op and post-op, that means that there's going to be some sort of analgesia, sedative sort of situation happening in between there. They're going into the procedural area, whether they're going in for a major like heart brain surgery, or whether they're going in and having a needle biopsy or a colonoscopy or a diagnostic. There is going to be a period of time where they're going to be awake, medical mystery time, they're not really aware of it. We do that out of kindness because otherwise it would be really mean. And then there's going to be when we're going to wake you back up. So that can create a lot of fear. In addition, people can be very fearful about the post-operative pain. They may have an altered body image. Think of the person who needs to have something removed because it's causing cancer. Like if I had a lot of people in the ICU. We had a doctor who was amazing. He would take throat and jaw cancer patients, and he would take out their cancerous jawbone and replace it with part of their shin bone. But then there's this recovery period, and then they would have a skin flap usually as well. And so that altered body image about how is this going to look? How am I going to be perceived by people after this? And then there's a disruption of their life too. There can be a variety of different things that can be considered a post-operative disruption of life. Sometimes people with colonoscopy are having colonoscopy because they've had like a failed laboratory test. So they may have fear that they have colon cancer, and and they could like go all the way down that loop. I'm going to have to go through chemotherapy and radiation. I'm going to possibly have a colostomy bag. Am I going to be, and then there's a whole bunch of altered body image, disruption of life, and pain problems that are surrounding your preoperative patients. They are anxious. So be sure to, the preoperative nurses, successful preoperative nurses, have a lot of education, and they're very supportive because there is a lot of psychosocial mental health that you're going to be talking about on Tuesdays with Britt, right? There's going to be a lot of mental health stuff that goes into a preoperative situation. There also may be an inability to cope, where they just don't see where this is going to happen. One of my friends, this isn't a nursing story, this is a friend's story. One of my friends had a gunshot wound to his lower leg, and it caused him severe amounts of pain, and they tried everything they could to save that leg, and they couldn't. So he's a just above the knee amputee. So he has a artificial knee and then an artificial leg and foot, like it's all one piece. And at first he was very fearful about how he was going to cope with that. And secondly, he was very fearful about how am I going to work, and there was a significant inability to cope with his particular diagnosis because he needed to have that amputation happen. Again, in that particular case, he had some altered mobility. Sometimes these surgeries are going to be creating altered mobility. Some of you had clinical on Mary Bry 5 C and F, and that Mary Bry 5 floor had a lot of post-operative heart surgery patients. How does a person who has a sternal incision right here, they don't really have a breastbone, so they don't really have as much mobility with their arms. If they're used to pushing out of a chair with their arms to be able to get up, they can't do that anymore. So we do a lot of education pre-operatively to warn people about different mobility alterations that they may have after their procedure. And just take a moment for yourself. I'm probably going to give a pregnant pause here in the audio. How would you provide psychosocial preparation for a patient? All of you will be getting some sort of preoperative experiences. How are you going to do that? Okay, so let's move into the next slide. So there are some different, like I warned you, there is a lot of terminology that comes along with pre-op and post-op. This is one of those pre-operative, post-operative, very important terms. NPO, nothing per oral, no oral intake. Because the risk of aspiration while they're in the procedure is so high, huge high, like enormous high. We don't want them to have their stomach contents come up and then go back into their airway. Like, because that's a real possibility when you have somebody in procedure where their stomach contents will empty, they'll go up the esophagus, instead of coming out their mouth, they will actually go down into the airway and cause all sorts of havoc. Imagine stomach acid in your lungs. Almost everybody in their life has puked one time. Imagine puke not coming out of your mouth and going into your lungs instead. Ouch. So, and sometimes there are different rules. So for elective surgeries, scheduled surgeries, NPO is very easy to do. For emergency surgeries, that's sometimes we just need to take a really detailed history, but the need for surgery is higher than their risk for aspiration, even though they're kind of like competing priorities. But if that need for surgery is higher than the last time or their last time they ate, we may have them hold off for just like as long as we possibly can, and then we're going to get them into the OR and get things taken care of. Like, we're not going to somebody who, like, let's say for whatever reason, somebody is at the Olive Garden and they just finished their pasta and they have a heart attack. We're not going to have them wait 8 hours to have heart surgery after having a heart attack at the Olive Garden. But when people are getting transported to the emergency room, whether it's their family member or the client themselves, somebody needs to tell us, hopefully, or have an idea about when the last time they ate. There's different precautions that anesthesiologists and CRNAs can take, depending upon what time they ate. But we do need to know what the last time they ate was and kind of have an idea about what they ate too. Ambulatory, same day, and outpatient surgeries can happen in little remote centers, or they can happen in the hospital ORs, depending upon your community and what the facilities they have, and depending upon doctor's preference. So some communities have outpatient surgery centers that specialize in orthopedic stuff. Some people have outpatient surgery centers for depending upon what they've got going on. And some communities, all they have is the ORs. So it really will depend upon what your community is. But in terms of eating, MPO and that, ambulatory, same day and outpatient, that's going to be surgery specific. So if they're having their gallbladder out, which we'll talk about when we talk about cholelithiasis and gallbladder, that's going to be something where we're going to want that GI and that colon to be really empty. If they're having colonoscopy, we're even going to give them emptying stuff. If for whatever reason, let's say they're having a wrist surgery, like they have a cyst on the wrist, or they need a carpal tunnel release surgery, or something like they're having their knee scoped, like a diagnostic on the knee or a shoulder, like, why are you having so much pain? We're just going to do a diagnostic on this. There may be some different rules about what the oral intake can be. So oral intake is very specific to each surgeon and each procedure. So you can have the same procedure and you can have different rules from surgeons. And I'm so sorry that that's the way it is. There's some general guidelines, but you've got some people who are just like, oh, well, they can have, I don't want them to have anything before their cardiac catheterization. And then there are other people like, oh, they can have toast and juice, that's fine. And I mean, they can't have a full like Grand Slam breakfast from Denny's, but they can't, it's surgeon's preference, and it depends upon the procedure. You're going to have some really good orders, and you're going to need to ask some definite questions when the client comes in to determine how they are on those orders and where their intake spectrum is. So this link works in your PowerPoint, and it is a pre-op nursing checklist. It's just one example. Like I said, it's all of this needs to be done, and it needs to be done before they start their sedation drugs. So I'm going to let you do an independent exploration of that and find that on your own. Let me just do a real quick peek here. So pre-op meds, we're going to need to make sure that we know what their allergies are. So you'll hear me say this a couple different times because we talk about infection and we talk about a couple other things here in class. I'm allergic to penicillin. Please do not give me Zosyn, ampicillin, penicillin, no cillins for this particular person. So everybody in, it's part of my chart, and it's confirmed every time I go in, no penicillins for me. There are other people who are allergic to cephalosporins and sulfa antibiotics. We need to know that. We also need to know some different things about what sort of meds they're on normally. When did you last take? Look at these. What are all of these? these caution meds, this first one. Go back to pharmacology last semester. I know it was a really long time ago. What are all those? What's the side effect of all those in that first point? If you said they increase their risk for bleeding, you are correct and you get a gold star. I don't have a gold star to give you through the video, but you get a gold star, an honorary gold star, an imaginary gold star, but a gold star nonetheless. So aspirins, Plavix, ibuprofen, warfarin, Coumadin, apixaban, rivaroxaban, your Eliquises, your all of your different blood thinners, all of your different things that are NSAIDs, all of your different anti-inflammatories, all of those things that we do to we have these medications to keep the blood cells slippery, right? So that they don't make clots. But we're going to take them into surgery. And when we're taking them into surgery, we're going to need some clotting ability because we're going to need to be able to heal tissues. So we need to know when they had those medications the last time. We're also there are also some different herbal products that really create a problem and help those blood cells stay slippery too. So vitamin E, fish oil, ginkgo, and garlic all increase the risk for bleeding. And we're going to ask these people, and a lot of people are on vitamin E and fish oil to be able to help with their cholesterol medication. They take them in addition to their cholesterol medications to be able to help with the passing of extra cholesterol into the stool, and it doesn't go systemic, and then they have lower the cholesterol numbers go down. Ginkgo and garlic are often used to be able to help memory and to help improve brain performance, but all of them do increase the risk for bleeding. So we're going to ask those clients who are using those as a therapeutic tool to be discontinuing them 2 to 3 weeks before. We also need to know what sort of recreational drugs or alcohol that they may use for 2 different reasons. Some recreational drugs will stay in your system for a while, and they may mess with the different drugs that we're using for anesthesiology and sedation. The other thing that we want to know is if they are a regular drinker, they could have some problems with their post-operative recovery time because they may be going through withdrawals. Recreational drugs, there's also a possibility of withdrawals as well. So if we are, depending upon the different drugs, then we have a different withdrawal protocols. And sometimes we will have the clients go through therapeutic withdrawal first in the hospital as an inpatient, and then we'll do surgery. We can also sometimes do surgery if there's need for the surgery is more important. And what they need surgery on is probably going to kill them first rather than the detox. Then we'll have surgery first and then we'll have detox. But it can be really, really delicate situation. So a very non-judgmental attitude and a neutral way of asking questions in pre-op saves people a lot of different embarrassment, and they'll be more likely to share these sorts of things with you. And then therefore they're more likely to have better recovery, because pre-op is all about, most of pre-op is all about having a successful surgery and having a successful recovery. It's laying the groundwork for successful surgeries and recoveries. There are also some surgery specific pre-op meds in table 17.8 in your book that you should take a look at. So in your pre-op handoff, this is an interesting slide. This green pea, this is not Kool-Aid, and it's not weird Gatorade, and it's not weird beverages from the bar. And this actually happens as a reaction to propofol in some people's body chemistries. So ICU nurses who are using propofol, or propofol also is used in the procedure itself. You may have urine that becomes this color, and it's a body chemistry reaction by certain bodies to the medication of propofol. So just to let you know, that's a real thing. Are they allergic to nuts? What sorts of allergies do they have? We need to know what sorts of allergies they have so that we can get that to be as less a factor as we possibly can. Do they have any other wounds? Are they coming in with wounds? This particular wound looks like it could have been from a fall. Whoopsies, I didn't mean to advance the slide. So this particular wound looks like it could be from a fall. What is their fall history? How they've been falling? This is going to be changing how we work with them in recovery, right? This person had a fall the other day. This is where their contusion came from. If the pre-op people have don't have sufficient notes about any sorts of injuries that people are coming in with, and somebody finds them down the line, the hospital could be charged with treating them for free because we didn't do the right documentation at the beginning. So let's do the right documentation. Please, she says, please, let's do the right documentation at the beginning. So I'm going to hold here. I'm going to stop sharing. This is chapter 1. And I am going to move into chapter 2 of pre and post-op. We're saying just after this. So take a little break, come back for the second or for chapter 2.